primary enrollers. And so I'm going to do a little bit on platelets and one stem cell, and then Jay's going to talk about really where we're going with cell therapy. Mine's going to be really quick, but I think points out some really important things about platelet therapy and where we should go. As a background to this, these are two platelet registries and large platelet registries, which we played a key role. Vicky's here. Amy, I think, was the nurse involved in both of these. And we're going to talk about them. But the background of this is we have, for dual antiplatelet therapy, I think everyone is very familiar with clopidogrel and with aspirin. But we have two trials that we presented last year, I think, the key parts. One is the Plato trial. These are all acute coronary syndrome patients with planned PCI, and they are randomized to prasugrel 60 plus 10, clopidogrel 30 plus 75 for 15 months, and we'll look at the primary endpoints. It's important to remember about these trials. This is just acute coronary syndromes, and initially when these drugs, there was a big difference in price. Turns out now, depending on where you are in the United States, prasugrel is similar price to clopidogrel, if not cheaper. And then I'll talk about ticagrelor. The hallmark of the new drugs, and I didn't put this up for ticagrelor, but basically with prasugrel and ticagrelor are three things: faster onset, more potent, less variability. It's really the same with both. And what you see, and if you looked at clopidogrel would be down here with more variability. But you can see very fast onset, very small variability, and very potent. And what you saw in the trials was a significant reduction, whether it was non-STEMI or STEMI, a significant reduction in total events, which was CV death, non-fatal MI, or stroke. And a significant marked reduction in stent thrombosis. And for instance, at this meeting, I don't know if anyone saw you, but there's a new oral antithrombin agent that, people were looking. Well, I would look at this and say that either TIMI 38 or Plato were much more potent than that. Yeah.
With 600 loading doses, difference?
It's a really good question, John. We don't know that. It certainly wouldn't take away all this out here, the other things. And, yeah, you do, and they've done the landmark, which more than half of the benefit occurs after the initial part. But it's also been done, the 600, the principal, compared those loading doses with principal, and really there's a significant differences in terms of the potency with that as well. So the answer to that, we think, is no, and we'll talk about it. And Gravitas tested that a little bit in terms of the issue with the other trial was Current, which used double dose clopidogrel, 600 loading and 150 a day. And so there's still beyond that what we want. But my point is, this is the Plato trial, very similar, 13,000 patients, all acute coronary syndromes, non-STEMI and STEMI, and so very similar design. Clopidogrel used 375, which again was the standard dose at the time, and ticagrelor 180 loading dose, then 90 milligrams BID. And with this, you saw the significant reduction in the combination of CV, death, MI, and stroke. You saw a reduction in myocardial infarction, as well as a significant decrease in death. Okay, and it did that. This is overall cause mortality, which was reduced with ticagrelor, and it was no differences in major bleeding with ticagrelor, where there is an increase in bleeding with prasugrel. So this is just the background of this that we wanted to talk about. The two trials that we played a role in that we did, and we put almost 800 patients in ADAPT. So these are our patients when you look at it. And what we did is we did a registry, a large registry, looking at the relationship of platelet responsiveness and stent thrombosis after DES. And the key part of this trial was if patients enrolled, basically anybody could get in, and we'll go through this really quick. But then what they did was the next day they got a Verify Now antiplatelet test. And so what this really did is looking at platelet responsiveness to aspirin and to thiopyridines and look at those responses. So Greg Sohn presented it. I think the background of this is that there's correlation between hyporesponsiveness to ADP antagonists and stent thrombosis. There is still a lot of questions. What percentage of the risk of stent thrombosis at different times can be attributed to platelets? So people get stent thrombosis. It's a small percentage. some of it's probably to hypo-responsiveness, but some of it's also probably to poor compliance, some of it's poor technique in terms of putting them in, some of it's because people are procoagulant. So it's a mixed bag of why people get stent thrombosis. And what's the best cutoff for stent thrombosis, okay? And is it important in all patients, or are there selected patients? And I think we have some insights in this, which we'll talk about. Okay, and again, the role we're going to look at not only the absolute level, we're going to look at the percentage of platelet inhibition. We'll come to those. And we'll look at both to aspirin and to I'll show you in 2 seconds. It was up to 11,000 patients at 11 sites in the U.S. and Germany. Basically, anybody with a PCI and using a non-investigational drug-eluting stent was eligible. There were very strict criteria about the aspirin and the clopidogrel loading, and then we used the Acrometrics the day of. And we were blinded to these results. And the reason why I want to talk about this is because now we're doing a trial with Translate where we're not blinded to the results. And I think we should make a decision about how we deal with those results, okay? And we're going to, after this is we presented this, we're actually going to send out a letter to the practice. But I have some thoughts. So you had to have, it was mandatory aspirin loading, mandatory clopidogrel lowering, and you couldn't be on a 2B3 inhibitor. So it was really a pure set of patients to look at platelet studying. If you look at this, we were about 5th overall, so we played a major role. 800 patients. Who are the patients? About 30% are diabetic, 22% ongoing smoking, 42% prior PCI, really pretty similar to our practice, actually, and we were pretty well matched to this overall group. There was half stable and half acute coronary syndrome, and of the acute coronary syndrome you can see here. Now when we talk about Translate, Translate is just here. So the trial we talk about at the end is just these 2 groups of patients. And you can see one vessel disease was evenly divided between 3, and in general normal to LV function. So pretty straightforward standard angioplasty in our clinic. This is pre-admission. This is what patients have been treated with, and at discharge, 99% were on aspirin, 99.7 were on thiopyridines. But for this trial, it was almost all clopidogrel. So this is all this data effectively is with clopidogrel. These are where you could see it was evenly distributed. The number of lesions were 1.7 stents per lesion, which is exactly what we average. If you look at it, 60% was either Promus or Xiant. And that's what it is. In fact, even a little lower than national average, but you can, just to give you a perspective, it was the newer generation stents, and I think that's important. Okay, so we measured at 19 hours after the trial, and here's the interesting thing. 5.6% of patients had aspirin unresponsiveness, so not very common, okay, and really not an issue at all. Sorry. And greater than 208 units, which is pretty low, really, for PR, platelet reactive units. If you do the Verify Now, 43% of our patients were actually over 208, which is very common, and 35% of the patients were actually over 230, which we think is pretty high platelet reactivity. So this is inadequate response to clopidogrel, basically. And so the point is, it's a pretty common problem, and we're going to keep coming back. Now, if you look at the percent inhibition, it averaged 40, and we're going to come back to this. If you look at the stent thrombosis, there's an important thing. Very few, only 39 patients in the first 30 days. And it was 0.46% of the patients. So using new techniques in good centers, the fact is that 30 days stent thrombosis overall is pretty low. And I think this is one of the issues. Do we use Verify Now? The answer is going to be no for the majority of patients. You can see where they were clustered, most in the early days. Now, this study will follow for 2 years, so we're going to get some more information about these patients. You can see this is the different definite and probable, but still likely stent thrombosis right there. Now, if you looked at what correlated, and I'm going to just really go quick on this, you can see that if you had stent thrombosis, 74% of the patients were PRUs over 208 versus PRUs. But there's a lot, and they're very statistically significant. But there's a lot of overlap in these groups. If you had platelet inhibition less than 11%, you can see it was, but there's a lot of overlap. And that's the problem. It's a low occurring event, and there's lots of overlap. I'm going to show you that with the next slide. We don't know for sure, but in the first 30 days, almost for sure it's great. Okay? It's important to know, because I think, you know, these are our patients, and we are putting a lot of these people in, so this data is coming from us. And I think that's why we wanted to show it. So if you look at your higher, these quartiles, or quintiles actually, the top two, which is over 217 or over 276, you can see most of your stent thrombosis occurred up there. In the lower ones, it was very rare. If you look at PRUs greater than 208, you can see again, it was much higher up there than it was down here. So certainly in this group down here, you don't need to worry about it. If you look at platelet responsiveness, so this is less than 11%, all of it really occurred up there. You can see down there. So if you can identify a group of patients who are not responsive to clopidogrel, you can. All right? And if you look at the lowest quartile again, you can see you can get separations between the two in terms of stent thrombosis. If you look at it, these are the three things, greater than 208, greater than 230, or 11%, which is the most powerful predictor, and clearly there is an increased risk score. This is the problem, is that if you look, this is the majority of people without stent thrombosis, this is the ones with stent thrombosis, you can see the overlap, right? So you're never going to be able to pick it out. Likewise, this is the percent less than 11%. This is the majority, and this is the ones with stent thrombosis. You can see it. You can tell a difference statistically. In an individual patient, it's hard. Okay? Another really important point is if you have stable coronary disease, the event rates overall are so low, you should really forget about ever using platelet testing in these patients. You really don't need to. If you need it at all, it's in particular the STEMI patients. Okay? And that's pertinent to the last slide. So the number one, the events did correlate to clopidogrel hyporesponsiveness, but they were not well related to 30-day stent thrombosis. This is the aspirin. I didn't go through that. Overall platelet responsiveness and aspirin didn't really correlate very well. It's really clopidogrel responsiveness that compares. The problem is when you apply it to very large patient populations, if you wonder why TIMI-38 and Plato are positive and significantly reduced stent thrombosis and events, it's because of those clopidogrel responsive patients. There's no question about that, why that happens. But the problem is, in an individual patient, to use platelet testing to guide it, I think is very difficult. And one of the issues is, should Alina do platelet testing on all patients? And it's been brought up from the other sites, and I think the answer is no. Okay? Certainly for stable disease. Now we have a chance to actually look at that and translate, which is what I'm going to end with, okay? Which is there. And there is a 2-year follow-up. So we'll hear more about this of does it matter more over time. I suspect it will in certain people. Remember, we are blinded. Now, this is a really important that I'm going to go really quick on. So I'm going to give Jay more than half the time. And this is the Paris registry, which we are also in, which we also put nearly 1,000 patients in. And we were the second highest enrollers. And what we did here is just what Rob was getting at, is patient compliance. So these are our patients. And we know that compliance is a big issue. It's recommended if you have dual antiplatelet for bare metal for 1 month, for 1 year for drug-eluting. But if you have an acute coronary syndrome, you should be on it for 12 months regardless of the stent type. And I think that's lost on a lot of people. It should be regardless of the stent type. And that premature discontinuation has been associated with increased stent thrombosis. So what we did is, with this trial, patients were actually called at 30 days. And I'll show you. It's very nice. It's the best trial ever in terms of looking at adherence. So multi-center, 5,000 patients, followed for 24 months. It's both bare metal and drug-eluting. And they grouped it into discontinuation. And this is patients where the physician makes the decision. the interruption where this is the patients do it, and this is really, this is interruption again with a physician for surgery mostly, and then they restart it. And then disruption, which is really non-compliance. And then, so they broke it up, non-adherence, into those three different things, and I'll show it really quickly. Basically, anybody that got a stent, any diagnosis could get into the trial, and only people who had stent thrombosis couldn't get in. And the goal was to look at non-adherence. We were actually 14% of the patients were actually here. 700 patients. Columbia was first, so we were second. It was a worldwide trial, but we were again ahead of all those patients. If you look at it in discharge, 100% were on aspirin and thiopyridine at discharge, so almost all were on dual antiplatelet, and proton pump inhibitors were about 20% of people. If you look at the number of stents, again, it was very similar. Mostly were one stent. Most of the patients were drug-eluting stents. If you look at the stent types, again, most of these were Promus or Xience, so the new generation stents. So this is contemporary therapy. Now, at discharge, most of the patients were on clopidogrel. So again, this is primarily a clopidogrel trial. Now, what's interesting is if you look at the non-adherence, it was only 2% at 30 days. So that's pretty darn good, and I'll show you where that compares. And it was evenly, most of it was disruption, which is the non-compliance. Interruption for surgery was smaller, and doctor deciding to discontinue it was even smaller. And there's two things. This is any non-adherence, which is 2% divided that way, but half of it was to the thiopyridine, similar, and half of it was to aspirin. So really, the percent stopping clopidogrel, for instance, out there is only about 1.5% at 30 days. Pardon me? No, yeah, but they called them up, and you're right, it is. But it's a direct interview with every patient. So it's as close as you can get. Now, the reasons for disruption, if it was a thiopyridine, most was just non-compliance, same thing with aspirin. So this is the disruption part, which is the patient-related. If you look at the reasons for interruption, which is the doctors decided, most of it was surgery, a little bit of allergy. Okay, so this is not too surprising, but we'll keep following. You can see it was not just the cardiologist, was 40% decided to stop it, but a lot of other doctors are actually playing a role in this. So if you look, this is the discontinuous at 30 days. It's range, but mostly it's around 2%. You have this one outlier that's 13.6%. Now this was actually based on pharmacy records. So to Rob's point, it might be higher. If you look at if you're non-adherent, you have significantly higher events, MACE, death, cardiac death. You also have significantly higher bleeding, so these patients, the ones that do stop, are higher risk, but some of them stop because they're bleeding to start with, okay? And if you look at the Paris registry, the event rates in stent thrombosis, you can see 2.9% versus 5%, very similar to previously published data. So it definitely happens. It was only about 2% at 30 days. We expect this to go up as we go out. This trial will also be followed for 2 years, and so we're hearing more of it. It's just, I think, a good thing to know that we're actually getting this data on our patients. And I'm going to finish now with this. We have an ongoing registry that's just with non-acetylation MI and acetylation MI. I strongly encourage everyone to know that we're doing it and encourage patients to go in it. It's very simple. We enroll the patient and then call up at 6 weeks and get a lot of information. We get a monthly report, and I just put a few parts of the monthly report out there. This is our site, and this is translated. We get over the course of the whole study. We also get the quarter by quarter. To give you an example, and we can compare ourselves to overall to the United States. You can see we put in more patients with STEMI than with non-STEMI. So we're getting a lot of our STEMI patients in. But this is a very high-risk patient group, if you look at this, because they're all non-STEMI or STEMI. Remember that. This is our highest risk patient population. So it's helpful to get this. This is our site at baseline and at 6 weeks. translate patients overall at baseline 6 weeks. You can see overall we do pretty well. We use beta blockers a little less, but overall we're a little bit better. A lot of people dropping off with ACE inhibitors. But this information is available to everybody, and if we want to send it out to everyone each month, we can. If you look at, we also get rehospitalization, and this quarter, if you look at it, we had basically no rehospitalizations, and we have been running less rehospitalization than across the country. Okay, but finally, this is it. This is our site per quarter. This is overall. This is translate by quarter and overall. This is my last slide, and I want to point this out. So they call everyone up, and the percentage of our patients that are on low adherence to medication score is about the same. We're running about 5%, which is about the same as national average. So it is about 5% of patients that we need to worry about in terms of are they compliant. But this is what's really interesting. This is dramatically different. If you look at this whole thing, there's one dramatic difference in these reports, and we are way outliers. We're more likely, our patients are more likely to have seen a primary doctor, but they're way less likely to have seen a cardiologist. So in this trial, our highest risk patients, only 34% of them have seen a cardiologist at 6 weeks. I think that's a problem. You know, because these are our patients, these are our non-STEMI and STEMI patients. This is who gets rehospitalization. This is who gets stent thrombosis. These are the ones who have low LV function. Yeah, John? Yeah, in this quarter. In this quarter, we had low quarter. I know. Well, you know, one of the things is the primary care is high. It is. It is. It is practice style. But I can tell you that if you look in this group of patients, we have some opportunity for improvement. Because what we know is if you take the patients, just the patients with an EF less than 50%, we know from level 1. So all of us would agree they're supposed to have a follow-up echo. Less than half of them ever get their echo. And so, and part of the problem is these patients who I think are high risk aren't seeing cardiologists. So, you know, and I think that's, we should have, you can see across the country, you know, 66% are seeing cardiologists by 6 weeks.
Why is that? Your outreach patients are seeing
Well, because we've been primarily a referral practice, so we go back to the primary care doctor, and I think there's lots of reasons for this, and we actually can get at why it happens. You know, patients go home, they don't have an appointment. They have a number to call for an appointment, and that frequently doesn't get done. But anyway, I'm going to end with platelets, and I'm going to let Jay talk about, I have one, what did I do there? So our issues to deal with, and if you want to come up to, you can, and get ready. The key is, what are the issues that from Translate we should learn about cardiology follow-up? The second issue is, with all these Translate patients, we're doing platelet testing, and now it's aware of to us. And we met and talked with the interventionist a little bit, but I think we'll send out a letter, and we're going to talk with the interventional group again. But I personally think, based on what we just saw, as long as we have the Verify Now for free, I think, and it's non-ST elevation MI and STEMIs, I really think that if we have PRUs greater than 208, we should consider putting those patients on either prasugrel or ticagrelor. Does that seem like a reasonable thing? And so that's going to be available in the chart. Amy, how are we putting it in the chart right now?
I'm putting a note in the patients that enrolled, and there's a separate note that says research Verify Now value is, and I put the value in the addition.
I put the percent intermission. So.
I'll put both in, and then I also have been trying to notify the physicians who seeing the patient and doing the chart summary. The patients enrolled and really out of the
Perfect. The last point is for level 1s, just for Abbott Northwestern, we know that this clopidogrel is inadequate because we're getting patients to the lab so quick. So the level 1 MI committee has worked, and we're going to change either to prasugrel or ticagrelor. There's some pros and cons. The downside of prasugrel is the history of TIA and stroke, which you shouldn't give. The downside with ticagrelor is more long-term. About 10% of people get dyspnea, and it's a BID drug, so you have a little bit more trouble with compliance. Right now, ticagrelor is a little bit more expensive, but prasugrel is really the same as clopidogrel, at least until it's generic. So, all right, thank you.
Otherwise, pretty much.
Okay. So,
this yours? Yeah. Forward and backwards. Okay, great. All right, thanks a lot, Tim. As Tim mentioned, we had a lot of featured presentations at American Heart and at TCT. And one of the studies I presented at American Heart in clinical science late-breaking trials was LateTIME. And many of you are familiar with us pestering your patients to get them to enroll in these 2 stem cell trials following their moderate to large infarction. And these were these results. This was published online on JAMA the same day we had presented it, and then it came out at print later on in the week. But LateTIME and LateTIME trial and the effective intercoronary delivery of autologous bone marrow mononuclear stem cells 2 to 3 weeks following acute myocardial infarction. So we're in part of this group called the Cardiovascular Cell Therapy Research Network that was started by the NHLBI about 6 years ago to help the development of stem cell therapy in cardiac disease in the United States. And we are one of 5 sites that were selected: Texas Heart, University of Florida, Cleveland Clinic, ourselves, and Vanderbilt University. In addition, we were also encouraged to develop satellite cells, and we did a great job with that. We had then United, Mercy, University of Minnesota, and Mayo Clinic was a late addition as well. And these satellite cells contributed greatly to the recruitment to these trials. So what's the rationale for doing LateTIME? So one of the things that we're looking at in both TIME, which we'll present next year, and LateTIME is looking at timing of cell delivery. No one knows what the optimal time is to give these stem cells after acute myocardial infarction, because to date, almost all the BMC trials, and I'll just use BMC for bone marrow mononuclear cell, have given their cells within the first week following acute myocardial infarction, but none of those trials have ever been powered enough to determine what's the proper time point. So we also wanted to look at, well, what happens several weeks after acute MI, because that may be an important time period for our patients, because initially a lot of these patients are too sick, they may be on balloon pumps, et cetera, to participate in a cell therapy trial in the first week. Or alternatively, these may be patients that show up in our clinic a couple weeks after their MI for follow-up, and they weren't around during the first week. So there's a lot of patients that would still possibly qualify for cell delivery, but just at the 2 to 3 week time point. So the design of this was to assess the safety and efficacy of autologous bone marrow mononuclear cells given 2 to 3 weeks post-MI on global and regional left ventricular function. And we targeted, our enrollment was 87 patients with moderate to large, almost all had anterior MIs that underwent angioplasty and stenting and had at least moderate LV dysfunction on a qualifying echocardiogram done within the first few days after their infarction. And every patient in the cell therapy group got 150 million cells. And amazingly, this is the first trial ever to give the same dose to all their patients. In the past, all the other trials, you know, they would be 150 million plus or minus 75 million. So some people got 3 times the amount of dose as the same patient in the treatment arm. So we were rigorously giving the same dose to all our patients, which I think is an important point. And then our endpoints, as I mentioned, were change in global and regional left ventricular function from baseline to 6 months by cardiac MRI. And then our secondary endpoints were change in infarct size and left ventricular volume. So this is the study flow of this. So patients, you know, had their MI, went to the cath lab as part of level 1. They usually would get an echo within the first 48 hours. And if it was less than 45% and they met inclusion-exclusion criteria, then we would approach them about the participating in the study. They would sign consent, and then they would all go home and then come back 2 to 3 weeks later. So in the morning, they would get a bone marrow aspiration done on the 3rd floor, and then they would get their baseline cardiac MRI measurements, and then they'd undergo intracoronary infusion of stem cell versus placebo. And this is randomized 2-to-1 stem cell therapy to cell-free delivery, and then at 6 months they underwent their repeat imaging analysis. One of the things we also did here, which was the first in a cell therapy trial, was we used this automated local cell processing using this subtax device by BioSafe, and we did a lot of preclinical testing to validate that that this was created an equivalent product compared to the manual FICOL measurement. So FICOL is this density gradient centrifugation solution, and so that the mononuclear cell layer, when you centrifuge this, will come out at a certain layer and that you can isolate. And so this subtax device does this all automatically to create a more, what we think is a more uniform product. And this is the baseline characteristics of the groups, and they were all equally matched between BMC and placebo. The only difference between the two, and it's not shown here, is that patients in the placebo group had slightly higher heart rate on presentation, but otherwise the risk factors, et cetera, were pretty well distributed. So you can see here that this is their baseline LV function. So these patients did meet their criteria of having at least moderate LV dysfunction. About 70 to 80% of the patients received drug-eluting stents, and again, over 90% of the patients had anterior MIs. And with regard to the median treatment time, such as time from chest pain to ER visit, chest pain to PCI, door to balloon time, and time from bone marrow aspiration to fusion, you can see that these all were very similar, and in overall, both groups received their stem cells approximately 17 days after their myocardial infarction. This is the characteristics of the cell product. 150 million cells in the treatment group. The viability was extremely high, and the CD34 and CD133 counts were very similar to what had been observed in other studies. So this is our primary endpoint. Again, this was the change in global left ventricular ejection fraction from baseline to 6 months. And we were looking at the difference, and we were comparing the difference. And you can see that in the, so initially remember that those ejection fractions were here at baseline. So look how much recovery there was at 3 weeks when we did their MI. Part of that was due to probably MRI usually calls a higher ejection fraction than echo. But a lot of that, too, was also due to resolution of myocardial stunning. So there's a significant improvement in the first few weeks in ejection fraction just from resolution of stunning. So when you're using ejection fraction as a primary endpoint, you sort of have this moving target. And so the stunning resolution can be much bigger than any therapeutic effect that you could see. So it makes it difficult, I think, to use ejection fraction as one of your endpoints in retrospect. But you can see here that it only went from 48.7 to 49.2 in the bone marrow group and 45.3 to 48.8 in the placebo group. So this was a non-significant difference. Now, what about in regional functions? So we used both the infarct zone and the border zone, and we used the American Heart Association 17-segment model. And the way we delineated infarct from border zone was based on their delayed enhancement with gadolinium on the cardiac MRI. For the infarct zone, we took the 2 regions that had the 2 highest amount of delayed enhancement. And for the border zone, we then took the contiguous adjacent segments that had uptake between 10 and 75%. And again, you can see it's quite sobering that in the infarct zone, there is no difference between the improvement here, very small. Again, as you'd expect that the wall motion, which is our measurement of regional function, was much higher in the border zone compared to the infarct zone. But again, there was no change between the bone marrow group and the placebo group. And our secondary endpoints looked at changes in volumes and infarct size. Both groups had a small increase in end diastolic volume, no significant difference in end systolic. Infarct volume, which we'll come to in a couple other trials that we'll discuss, went down, but this difference was not significant between the 2 groups. And in general, infarct size always goes down, measured over the first, several months as the infarct gets resorbed, the edema resolved, and so you should always see really a reduction in infarct size over time measured with gadolinium. And as far as safety, this is an extremely safe procedure, and it follows the safety issues or the lack of safety issues that have been observed in Europe, and I have no idea why this did this, these funky marks there. But anyways, you can see that particularly in the bone marrow group versus placebo, there were fewer events in the bone marrow group compared to placebo. So this is only 6 months, and will definitely worth following this. But a couple other bone marrow trials have also found much fewer events with the bone marrow group compared to the placebo group, even when they didn't see a significant improvement in left ventricular function. So what would we conclude? We would say that the intercoronary delivery of autologous bone marrow mononuclear cells 2 to 3 weeks following angioplasty and stenting for moderate to large MI is very, very safe. Unfortunately, we saw no benefit of bone marrow cell therapy on global and regional LV function at 6 months. So in some ways, this was, we were disappointed that we didn't see a positive effect, but at the same time, I think we were very happy with how well the study was done. There was an editorial in JAMA by Josh Hare, and this was also commented on at the AHA meeting about how well this study was done. And sometimes negative trials are important because this, I think was very clear in our results that this time point's not a good time point to give stem cells. And that may be because there's changes that go on in the heart several weeks after that make them less receptive to engraftment and survival of stem cells, or maybe we know there's changes in the bone marrow so that the quality of the bone marrow product may change over time. And so we have a large biorepository, and we have cell samples and bone marrow samples on all these patients. So those are some of the things that we're going to look at in the future to try to help determine why cell therapy is really not effective at this time point. So, and now just quickly, let's just talk a little bit about myocardial regeneration in humans and animals, because it's really never been observed before in humans. But there were 2 trials that were presented at AHA on Monday that basically stole the thunder, and deservedly so, because they were both remarkable, and if true, then it's a true shift and major development for cell therapy in humans. So I just want to talk a little bit about this concept of endogenous cardiac stem cells, that within your heart you actually have your own cardiac stem cells, but unfortunately when you have a heart attack, it's not nearly enough, doesn't provide much bang for the buck to help repair your heart, but we know they're there. They were first identified in 2003 by Piero Anversa's group. They describe these cells as being lineage negative, and that means that these cells are very primitive. They haven't committed to a cardiomyocyte, endothelial, or smooth muscle cell lineage, so they're called lineage negative. And then they have a cell surface marker called c-KIT, and so you'll see this again and again. So these are lineage negative, c-KIT positive cells. They fulfill all the criteria of being a stem cell, and that they're self-renewing, multipotent, and clonogenic. So we know that some animals have remarkable regeneration capacity in their heart. This is a zebrafish, and you can amputate the lower fourth of the heart, as shown here, and remarkably within 30 days, the heart will entirely grow back. You can see that in red are some of the blood vessels that you get a concomitant growth of the vasculature at the same time to support the growing cardiomyocytes that develop down here in this area of the amputation. And so this is thought to arise by these cardiac, just basically mature cardiomyocytes undergoing, basically going back in time so that they're back into the cell cycle and that they start renewing and duplicating, as well as the presence of cardiac stem cells that are present that help this to occur. And this is a picture of some of these endogenous stem cells. They've been found now in pretty much every animal. Again, these are these cells that are in these little niches that are seen often in the atrium, and the green is the c-KIT positive marker, and the white dots show that these are they've already assumed in this picture these cells have already taken on a cardiac phenotype since they have this transcription factor NKX 2.5. And this is what this group, this is sort of the study that launched all these bone marrow stem cell cells in the world. This was presented in Nature in 2001 when they took these cells out of the bone marrow and they injected them into the infarcted rat heart like 5 hours later. and what they found was that 9 days later, they claimed that 68% of the myocardium had been replaced. This set off a flurry of activity with a lot of countercharges saying that this is just a basically this is because these were judged to be cardiac cells by immune fluorescence and not by, say, genetic, like using a transgenic animal, that they were subject to kind of variable interpretation. And indeed, several trials then later came out using transgenic animals that actually showed that the amount of regeneration is much smaller than here. But anyways, it was this picture and in this paper in 2001 that basically started the whole cardiac stem cell revolution here. So what about in mammals? Is there any regeneration in mammals? So this is a really interesting study that was just in Science or Nature, I don't know, about 6 months ago, that talked about transient regeneration potential in the neonatal mouse heart. So basically what this study did was they again did the zebrafish amputation here, and this is 1 day post-birth, okay? So these are 1 day old mice. And remarkably what they found was that in the mammal here at 1 day old, you can basically amputate the heart, and that this is just a blood clot sitting there, and then over time this all regenerates back into normal heart tissue, and that your left ventricular function in the transected group is the same as in your control. Now what's amazing is if you do this 7 days later, there's actually no benefit at all. In fact, what you see then is you get all this blue is all scar tissue. So remarkably, with it, just in the first week, the developing heart loses its ability to regenerate, but it's obviously there. So finding what those switches are that shut off these cells from being able to proliferate to when they can't, just a week later, would be important. Now, what about in humans? So this is a brilliant study I thought that was done in Science 2 years ago from the Swedish or Danish investigators. And what they used was the amount of carbon-14 that was in the atmosphere. So thanks to all our atomic bomb testing and everything, there's all this C14 that was in the air that was in between like 60s and 70s. And this curve here just shows the amount of atmospheric carbon-14 in the air, and thankfully it is dropping off. But this carbon-14 then rains down on plants, is taken up by plants. Animals eat the plants, you eat the plants. So basically you're taking up all this carbon-14. And so they can then, when you form a new cell, in your DNA incorporate this carbon-14. And so you basically have a tag, and you can then, knowing when the peak was of this carbon-14, you can use that to date when these cells were actually born. So, and this is backwards here. This should be after. So they had all these patients. They had these hearts that they isolated after these patients died, and they basically took all the heart muscle cells, and then they took the nuclei and isolated the DNA from these cells, and then they looked at the amount of carbon-14. So here are patients that are born after the bomb, and so these little circles are the patients born after the bomb, and they're right on this curve. And then these are the patients that were actually born before. So what you can see here is that the amount of carbon-14 in their heart is much higher than what was in the atmosphere at that time, suggesting that their hearts actually accumulated carbon-14, or their heart's nuclei accumulated carbon-14, which means that they formed new heart cells after they were born. And they did some very elaborate mathematics to basically show here, and I guess this is kind of, so this is the fraction of your initial cardiomyocytes that survive. So over time, you lose about 25% of all your heart muscle cells. And so there's a constant turnover in your heart. And there's an age-dependent decline in the turnover of these new cells that form. So about 1% a year up to age 25, you're replacing new heart cells in your heart. And then once you get after that, it's only like about 0.5% a year that you replace of your heart. So yes, there is, in the heart, the human heart, it does regenerate, but just again at a very low levels. And in the end, about 45% of all the heart muscle cells that you are born with get replaced. But remarkably, that means that so 55% of your heart muscles that you have at birth, you keep for your whole life. So that's kind of sobering thought. All right, so let's get to the two big trials here. One was by Roberto Bolli at the University of Louisville called SCIPIO, and SCIPIO was this like famous Roman general. So but it also stands for cardiac stem cells in patients with ischemic cardiomyopathy. And the other trial was CADUCEUS by Eduardo Marban, who's at Cedars. Both of these are using endogenous cardiac stem cells. So these are the first two trials that have used this whole theory of endogenous cardiac stem cells. So this was published online in Lancet the morning of his presentation. And what's remarkable is that this study was still in progress when it was done. In fact, this only had 17 patients in the treatment arm. So I don't know if Lancet ever published such an incomplete study, but the results were so, in some ways, sort of shocking and amazing that I think, they wanted to be the one that will always be known as the first paper to describe these cardiac stem cells. So what do? So first of all, this study, let me see if I have, so this is a post-MI-LV dysfunction. These are all patients undergoing CABG. They all had myocardial infarction, at least one, and their ejection fractions were less than or equal to 40%. And what they do is they transect the right atrium at the time of surgery, and then they send the right atrium to Piero Anversa's lab in Boston. He's the one who discovered these cells. And then they basically isolate these c-KIT-positive cells, and then they send them back to Louisville, Kentucky, where they're infused really 3 months later. And each patient received up to 1 million of these cells. And this is what some of these cells look like in the patients. And you can see that, I wish I could read, I can read it up here. This is, so the high percentage of c-KIT positive cells here, and then a very low number of cells of lineage-committed cells. So again, this fulfilled, I think about 90% of the cells were lineage-negative, c-KIT positive cells. And this trial, it's amazing that, again, another limitation of this study was the way they enrolled patients. So they had two different strategies. Stage A, they would just consecutively enroll patients. It was open label. The only thing blinded was the 3D echo that they looked at. But so they took the first 19 patients they gave stem cells to, and then the next 6 they made control. And then after that, then they switched over to a more randomized study. But you can see that there are patients then that switched over. They said, no, I don't want to get placebo. I want the real thing. So, I mean, the kind of the rules that they used for this study were incredibly lax, which is another amazing thing how it got in Lancet. But again, the results, I think, are so surprising that it allowed that to happen. So a subgroup of their patients had cardiac MRIs. And so this is the surprising thing, really, was two things. One is that the infarct size, we know it went down significantly over time, over 12 months. And I don't have here, but the ejection fraction went from 30 to 38 to 40 at 4 months and then 12 months. So that's by far the highest improvement in ejection fraction. And this didn't have the benefit of having stunning resolve that gives everyone a boost in their ejection fraction. These were chronic ischemic patients. And their control group, the ejection fraction went from like 30.2 to 30.5. So that's, I think, what was so surprising is that these had a significant effect on left ventricular function. So I think the data here was shocking, and it warrants obviously a phase 2 study. Theoretically, Bolli is going to get into our cardiovascular cell therapy network, so we will have access to this study, and we will probably be participating in one form or another using this new type of stem cells. There are obviously a lot of concerns. It's a small, open label, and it's not even done yet. There's no intention to treat analysis, and had high withdrawal rate from the control group. So it's clearly not without its warts, but the results, I think, are pretty surprising. And then finally, in the last minute, we'll talk about, this is from Eduardo Marban, and pardon my French, but boy was he pissed that Bolli beat him to the punch as far as being in the, getting published. In fact, Marban chaired another group at AHA where Boley had to present, and I've never seen, you know, bordered on rudeness how cold he was to him, and, you know, tried to pimp him on questions and everything to kind of trip him up, but, you know, Boley was up to it, and it didn't happen. But so this, again, is an amazing study as well. This is a post-MI study where the first one was post-LV dysfunction. These patients all had MIs 30 days prior. They had ejection fractions of 25 to 45%, and it was a 2-to-1 randomization of dose escalation for preliminary efficacy for cardiac MRI for mass, volumes, and function. This involved their Cedar Sinai and then Johns Hopkins, where Marban was up until a few years ago, and where this study really got started. They performed endomyocardial biopsies to develop a different type of endogenous cardiac stem cell, which is called the cardiosphere-derived cells. And this is a picture, so you can just see how easy this can be. You just take the small biopsy specimens, you plate these in growth factors, and then you start getting these little cells that come out from these are these cardiospheres down here that you see here, and you take these small cells from there, and then you basically inject them by an intracoronary infusion down the infarct artery. And that was done then, so it takes about a month to grow these cells. So again, this was then given like 3 months after their heart attack. The age is 53, all males. New York Heart Association class 1.3. These are almost all anterior MIs. The initial scar size at 1 month, again, was 24%, and the ejection fraction was 39%. Okay, and now here is, you know, of course they always give you their best one to show when they say, oh, this is just your typical patient. Well, we know it's really not. You take your best patient. But you can see here, so here's the infarct area from here to here, and then at 6 months you can see how that actually they would say that this infarct size got a lot smaller, whereas in the control group there was, you know, there was really no change. So you're saying, well, show me more. You could have manipulated that. And so now this is the scar mass versus the viable mass between at 6 months and 12 months in both the control and the CDC group. Okay, so you can see here that these cardiac-derived cells, look what happened to their scar size. It went down significantly by like 9% at 6 months and like 14% at 1 year, where the amount of viable mass or viable myocardium went up significantly compared to the control groups. It didn't change at all. So Marban would say that this is the first trial that has ever demonstrated regeneration in the human heart. What was interesting now is has Boley's ejection fraction went from like 30 to 40% in a chronic ischemic. Their ejection fraction really didn't change at all. So that sort of, you know, says, well, you know, why is that? Well, they did look at regional function, and they did find that the strain rate in the in thickening improved in the cell-treated group compared to placebo. So what was interesting, maybe John could comment, because Chuck Murray, who's a very famous researcher, so Marban presented right after I did, and so there was a discussant with each group. And so the discussant was Chuck Murray. And the only thing he said is, we know that these cells are very vasculoprotective, and the fact that the gadolinium, part of the reason it's uptake in the infarct zone is you have this leaky vasculature. And so maybe what you're really seeing instead of regeneration is that you're actually just seeing is that these vessels aren't as leaky, and so there's not as much gadolinium that gets taken up, and so it makes it appear that your infarct size is a lot smaller. So John, does that?
I think there's a lot of things in there. I think technically you would be more likely to find an effect if you measure global mass that's not involved, then you measure the ejection fraction of each of them. And the study from Atlantis doesn't make a lot of sense to me. The one thing about it, they were vascularized. There was hibernating on it, which is similar to your recovery.
Right.
So that I don't know if that affects this thing. But the strain issues would be a much more sensitive measure. And there is this genetic sequence that you use, and you can use 2 types of strain, which we actually have now. going to be a better way of trying to look at this? If it's less leaky, that might have some positive effect. Strain correlates with that. That wouldn't be bad.
Okay. Good. So, again, this is the second study that got an incredible amount of press, but the conclusions that the author draws are quite strong. That basically this is the first therapeutic modality that shrinks scar while regrowing viable functional tissue. So, to be determined, but you know, certainly these results are results we haven't seen before in any cell therapy trial. Yeah, John?
It's a big thing about how you measure it, and there's a lot of technical issues. Did you make any mention about that at all? You do it visually as a method, and you have to do it with a threshold in sequence.
Well, they certainly didn't in this, and so and there hasn't been a paper out where you can actually kind of dive into the methods and see. So, Adrian?
Hey, what is the difference between the cells and those studies? In this study, are these stem cells?
Yeah, they're endogenous cardiac stem cells.
But they're not the same as in the first.
Well, so they may share initially, but you know, you throw these cells in culture and then they start taking on life of their own, and so it's really, you know, unclear. I mean, they're basically, in one sense, a product of the culture environment. I mean, you can make cells express anything you want depending on the growth factors and the medium and things that you use. So the first study were these lineage negative, these c-KIT positive cells. So they just have an antibody with a magnetic bead that attaches to the cells, and those cells that have the antibody get selected out. These are these cardiospheres, which basically are these cells that you put in growth factor. They adhere to the plate, and then, you know, they start shedding these, you know, these clumps start shedding these small cells that are called cardiosphere-derived cells. And I don't know if he commented on if any of these things were c-KIT positive.
I think there's a lot of discussion about that, but they're both autologous, you know, myocardial-derived stem cells. There's certainly significant overlap between the two. Certainly.
So only like 15% of these are c-KIT positive, whereas in Boley's study about 90% are c-KIT
positive. But in the study you reported, those were stem cells.
Ours were just autologous stem bone marrow derived mononuclear cells, so they were way different cell type. Nick?
You guys have done a lot of free stem cells, growth factors, and genetic material, and all that. It seems to me that this is the work we need to control signals. Try to tell the cells what we want to do. Have people been doing things together with growth factors and stem cells and that sort of thing?
So one of the biggest effector of stem cell engraftment and recruitment is this SDF1, stromal derived factor 1. So one of the people that worked with us in CCTR has actually developed a gene therapy study, this company, and formed his own company, Juventus in Cleveland, and actually then these cells then express higher amounts of SDF1 to kind of basically improve recruitment and engraftment to the myocardial region. So one thing that we know is that this SDF1 peaks for several days after a heart attack, and then it goes down. So that may be one reason why at 2 to 3 weeks, you know, we didn't see an effect. Alternatively, you know, it just may be that the bone marrow mononuclear cell, and that's what I think is a very weak cell type, and so we clearly need to get into newer cell types, or else we have to, you know, transfect these cells with growth factors such as IGF-1, HGF, SDF1, things to make them a lot more robust than what they are. I think autologous cells are you know, from sick patients aren't that great, whereas, you know, some of the allogeneic studies that use, you know, cells like we participated in Osiris, all the cells came from one young healthy donor. And, you know, so the cells from a 20-year-old are much more robust than a cell from a 70-year-old smoker with diabetes. So I think part of our failure, too, I think there are these bone marrow mononuclear cells. They help a little maybe, but they're clearly probably, you know, a weaker stem cell type than some of the others that are out there. Rob.
Hey, what about like taurine? Are they going after
Adipose?
exactly?
Yeah.
And then the second question is, possibly goes about this in my cardial injection is better than is there any evidence that from the method of delivery at this point?
Well, I think you get greater, you probably in some studies will get greater acute delivery with intramyocardial, but overall the difference isn't that great. And the problem with intramyocardial is that you're so limited in the areas that you can target, whereas with intracoronary, you get a much larger target region. There's also a little bit of concern about sticking these needles in the heart right so close after a myocardial infarction. So we tend to use that technique in our chronic ischemic studies where their scar is stable and thick, as opposed to acute MI.
And the utmost reliance now, that's considered as promising.
Yeah, no, sure it does. I mean, that's mostly an MSD-like product, and you know, there are studies that are finished in Europe, phase 1 studies that got presented at AHA, and you know, it looks okay. It's nothing like CADUCEUS or SCIPIO. It's more, so far seems more like, and Tim didn't have time, but he was also going to show the mesoblast data. So that's kind of maybe the next generation of an allogeneic or autologous product from either adipose or from bone marrow.
So to follow that up, 3 really quick things. First of all, the SCF1 on the gene therapy, which is what Nate brought up, we'll be the first ones we actually, the gene alone, we're going to use it with critical ischemia patients and with heart failure. So we'll be actually, we're effectively going to be in charge of both of those trials, and both of those will start, the CLI trial will start within 2 months. And the second thing is, the other approach is to do better cells autologous, which are these cardiac drives. But the other approach is to use allogeneic, which is young, healthy donors. And what I didn't show you, but was also a late-breaking trial that we were the top enrollers in, was the angiblast or mesoblast trial. And 2 important points. We treated 60 people, and even though these were allogeneic cells, so all the cells came from one young, healthy donor, they're very well tolerated. There were no immunologic, we did very careful immunologic evaluations. They're very well tolerated. And no issues, no clinical issues at all. Second of all, it's a very interesting thing that there was a minimal effect on the immune protection, a slight but minimal. But what you did see is a dramatic decrease in cardiac events. And it's interesting because the LateTIME trial, we reported as negative, because it doesn't change the immune protection, which you saw in the event rate, 17% versus 5. And what now you're seeing consistently over and over and over again in trials is that there may be benefits that are not just related to ejection fraction. And that because over and over in the trial, the event rates in the treated group are significantly low. So, we'll see. And then the final point was, these are all LV dysfunction, post-MI and heart failure. A whole different group is the refractory angioedema. That's, I think, those are speakers more positive cells in general. These are really cells that grow blood vessels. And that's what people for refractory angina and for critical ischemia, that's where the data is the most positive. Growing new heart muscle is a lot more difficult than growing new cells.
One observation. Because of what you've been able to do, you can get access to all of these labs around the world and get the best, newest thing, and we still get that to our patients and to our team. But that's amazing, the relationship with all of them.
Yeah, I was just going to last one. Basically, you saw SCIPIO and CADUCEUS. Well, during the same time, SCIPIO now will be CCHRN, so we will be in charge of that trial, and we will drive it. Most of those patients are actually treated. And the second one is CADUCEUS was, 2 weeks before TCT, I went to San Monica, and basically, Marvin asked us to run their next phase of. So in both of those cases, we just use it itself, but give them to people and do it in well done randomized trials, they really need us. Which is good. And it's So, and Jay deserves tremendous credit because to give some perspective, this is an NIH-sponsored trial. This has never happened in the NIH. We basically started with INDs, got 3 trials completely done in the course of the month, and saved money for them. We met in August, the end of August, or September, the trial ended in the end of August, September 13th. We saw the data for the first time. 10 days later, the paper was submitted to JAMA and accepted to JAMA, and they presented it at the same time the paper was published, which is, and it's really unheard of.